this is a 3/8 of an inch or inch. But we're not talking about that today. Welcome to respiratory part 2. Oh, ah. Is pathology of the lungs limited to airspace disease? No. We have other structures within the thoracic cavity that can cause problems as well. Consider pleural effusions and pleuritis. Remember, the pleura are the linings around the lung between the lungs and the chest wall. Some diseases can cause a buildup of fluid between those linings, and that term is called pleural effusion. Certain infectious diseases, such as asbestosis and occupational exposure to asbestos, is known to cause pleural effusions. Other infections can cause pleural effusions. Cancer that spreads or metastasizes to the pleura can cause pleural effusions as well. Pleural effusions are basically a generic term for the collection of fluid between the pleura. I want to draw your attention to a specific term called chylothorax, which is a clinical term relating to the collection of lymphatic fluid specifically within the pleural space. You may hear terms like exudate, transudate, purulent, sanguineous, as terms that are used to describe the quality of the fluid that's collected there. Ultimately, if pleural effusions don't resolve themselves, they may need to be treated therapeutically by drawing the fluid out with a needle, a procedure called thoracentesis. Matter of fact, in patients for whom pleural effusions are a recurring problem, instead of a one-time thoracentesis procedure, you may actually see a thoracentesis type drain placed in so that the pleural fluid can continue to escape. If the pleural linings happen to be inflamed, the clinical term for that is pleuritis. Probably could have guessed that one, right? I also threw you another term here, empyema. Generally speaking, empyema refers to infectious fluid collecting within the pleural space, though I will tell you that technically you can apply the term to infectious fluid collections elsewhere in the body. Acute respiratory distress syndrome. ARDS. First thing I always tell people about acute respiratory distress syndrome is this: it is not a disease unto itself. ARDS is always secondary to a primary pathologic circumstance. Coronavirus has been in the news a lot lately as a preceding viral infection that in some individuals progresses to acute respiratory distress syndrome. But please know that coronavirus is not at all the only thing that could potentially lead to ARDS. There are many pathologic circumstances that can lead to acute respiratory distress syndrome. Now you'll see pictures of what's going on pathologically on the next slide, but basically ARDS is summarized as destruction of the alveolar capillary membrane, alveoli that are filled with fluid that then impair gas exchange, with the clinical consequence of severe hypoxemia. Now, this pulmonary edema, this fluid within the alveolus, is most often clinically caused by heart failure, a left ventricle that's just not moving fluid out of the heart. So one of the defining features of ARDS is pulmonary edema, hypoxemia, in the presence of someone for whom it can't be explained by heart failure, the much more common cause. Now here's a 4-step process for the pathogenesis that occurs within ARDS. The first event is injury to the alveolar capillary membrane. That little membrane that separates our little alveoli balloons from the capillary blood vessels that surround them. The second circumstance is, as that damage occurs, fluid shifts from the capillaries into the alveoli. And one of the important pathologic changes to note at this point is that surfactant production is severely compromised. And remember, surfactant is what lets our alveoli stretch out and create that surface area for gas diffusion from the alveoli into the capillaries and capillaries back into the alveoli. That leads us right to event number 3, whereby the loss of surfactant essentially compromises the alveoli's ability to stay expanded and starts really wrecking gas exchange. Which then again leads to event number 4. Alveoli continue to flood, which leads to hypoxemia and tissue hypoxia. And I'll just contrast really fast between those two clinical terms. Hypoxemia means low blood oxygen levels. Whenever you see the suffix emia, that refers to the blood specifically. And contrast that with hypoxia, which is a low level of oxygen within tissues. Ultimately, the pathologic result of ARDS is a low arterial oxygen pressure, that's PaO2, or more simply, hypoxemia, and shunting of capillary blood within the pulmonary vasculature. Now, you may have heard the word shunting in other circumstances, but when we talk about shunting in the setting of ARDS, what we're talking about is allowing capillary blood flow to bypass the alveolar without exchanging blood gases. Could ARDS lead to respiratory failure? Absolutely. Is it the only thing that can lead to respiratory failure? No way. There are lots of things that can lead to respiratory failure. ARDS is one of them. There are acute forms of respiratory failure. There are chronic forms of respiratory failure. It's a little bit beyond the scope of this course to talk about each one. But we should mention that at least the principle of getting to respiratory failure involves compromised gas exchange in the form of hypoxia or hypercapnia or both. Remember that our blood gases are what create our drive to breathe. Part of that autonomic drive that we all have, so we don't have to think about breathing. Patients that are leaning toward respiratory failure are throwing blood gases off so much that the drive to breathe starts to become stifled itself, ultimately leading to the point where they have no more drive to breathe. Respiratory failure. Much like ARDS, pulmonary artery hypertension is a consequence, for the most part, of some other pathology. So there's 5 basic categories that patients with pulmonary artery hypertension generally fall into. The primary one is maybe the pulmonary vasculature just isn't built the way usual pulmonary vasculature is built, and hypertension is the result because of whatever structural change is going on within the pulmonary artery. If those structural changes aren't inheritable, maybe they're caused by something else, local fibrosis within the area related to connective tissue diseases, such as pulmonary fibrosis. Another category of pulmonary artery hypertension relates to the cardiovascular system, and that's in the form of left-sided heart disease This is probably pretty easy to visualize because if the left side of the heart can't pump blood out into the aorta, that blood is going to congest backward into the pulmonary vasculature and raise pulmonary vascular pressures, ultimately leading to pulmonary artery hypertension. This concept of thinking about blood congesting backward is one that we will revisit quite a few times in cardiology. A third cause of pulmonary artery hypertension are chronic lung disorders. For example, asthma, chronic bronchitis, emphysema. These disorders over time and the inflammatory changes that result can result in pulmonary artery hypertension. The fourth category for pulmonary artery hypertension is pulmonary artery obstruction, as might be seen in, say, a pulmonary embolus, which we'll talk about in a few minutes. What if they just don't fit in any of those four categories? Well, then you got category number 5, which is idiopathic. A nice way of saying, I got no idea why you got pulmonary artery hypertension. Whoop! Now, pulmonary embolisms are kind of one of those things where we'll mention it at a few different points as we're talking about pathologic processes. First thing I want to say about pulmonary emboli is that they are blood clots, but they are a specific type of blood clot that has occurred in the lung vasculature or, more commonly, started within the leg venous vasculature. The clot in the leg venous vasculature breaks off. That's called a thrombus that turns into an embolus. Floats through the venous vasculature to the right side of the heart. Follow me anatomically on this. And then from the right side of the heart, that blood clot embolus gets shot up into the lungs, where it gets lodged into small lung vasculature vessels and blocks blood flow. Now, pulmonary emboli have a wide spectrum of severity, just like heart attacks and just like strokes. On one side of things is the low severity side. People have these pulmonary emboli and they're minimally symptomatic, if at all, and eventually the clot dissolves or stabilizes and things are good. On the other side of the spectrum of severity is a pulmonary embolus that's so large and blocks so much blood flow to the lungs that people are dead within minutes. Aren't you glad we live in an age where we're no longer exposed to air pollution and therefore will never have to suffer from lung disease caused by, say, occupational exposure to stuff? What's a malarkey? Got any coworkers in your family? Got a lot in mine. Which means a lot of black lung disease. Coworker pneumoconiosis. Is it the only job where an occupational hazard is lung disease? No! For many years, asbestos was used as insulation and in other forms, and people inhaled the small fibers and developed a lung disease called asbestosis. Is that the only thing? Are those the only two things? No! The inhalation of certain dusks or talcs can cause silicosis, another occupational lung disease. Now, all of these are serious, but I just want to point out asbestosis in particular because asbestosis has been linked to a very specific type of cancer called mesothelioma. You may see some of the class action lawsuit signs on the side of the highway. Mesothelioma is a very specific type of lung cancer, secondary to prolonged exposure to asbestosis. It doesn't show up until years to decades later. Unfortunately, it's very difficult to treat. Now, talking about asbestosis and mesothelioma does segue quite nicely into a chat about lung cancer. A little bit beyond the scope of your patho class to talk about every kind of subtype of lung cancer, and you already did the cancer module, so you understand tumor suppressor genes and oncogenes, abnormal cell signaling, alterations to apoptosis, and then, of course, cancers need to spread via metastasis and angiogenesis. So you're familiar with those four principles, and guess what? They all apply here. Lung cancer is, generally speaking, cancer of the epithelial lining of the lungs. I'm going to give you a little bit of terminology. Carcinoma. Carcinoma means mass, that's the ulva part, and then the carcino actually means spread similar to a crab, from the Greek word karkinos, for crab. Carcinomas clinically are defined as epithelial-based cancers. In the setting of lung cancer, it's cancer of lung epithelium. There are two broad categories, small cell and non-small cell. Non-small cell are then further subcategorized into adenocarcinoma and squamous cell carcinoma. And all three of these, small cell, adeno, and squamous cell carcinoma, are different cells within the lung epithelium. Underline that in your notes as well. Thinking about the cell of origin for a cancer is very important when you start to consider a cancer's characteristics. Let me give you an example. Small cell lung cancer's cell of origin is from a cell in the epithelium that has neuroendocrine capabilities. Now, if you don't remember what endocrine is from A&P, your endocrine system produces hormones. Neuroendocrine cells are cells that are able to produce hormones in a neurologic response to the environment that they're in. Small cell lung cancers, because they have neuroendocrine capabilities, are infamous for secreting their own endocrine hormones. Most commonly, antidiuretic hormone, or ADH, a little bit less commonly, adrenocorticotropic hormone, or ACTH. There's also an even less common manifestation of small cell lung cancer called Eaton-Lambert syndrome. And that's a situation whereby the small cell lung cancer generates through the body antibodies to the calcium channel receptors within the neuromuscular junction. Eaton-Lambert syndrome. Now, adenocarcinoma and squamous cell carcinoma are different cells within the epithelial lining of the lungs. And therefore, technically, they are different cancers and they are treated differently. Because we're in the genetic age, I want to let you know that of the three types of lung cancer that I have listed here, your two small cell lung cancers are the most genetically defined in terms of what oncogenes and tumor suppressor genes are going wrong. In fact, both of those cancers have treatments that are based on modifying the cell signaling pathways of the oncogenes themselves. In the example we have here, this is a normal cell within all of our lung epithelium, and this particular cell expresses the anaplastic lymphoma kinase gene and then makes a totally normal ALK protein, and that protein's normal job is to sit within the cell membrane and act as part of a cell signaling cascade. By the way, whenever geneticists refer to a normal gene and protein product, you'll hear the term wild type. So, this picture here just presents a normal or wild type ALK gene and protein and how it sits in kind of that intracellular portion of the cell membrane. And it sits there to act as a conduit or a bridge protein between ligands outside the cell and cytoplasmic kinase proteins inside the cell, which then send a cell signal to the nucleus to grow and divide, tightly controlled at all times. Now, in roughly less than 10% of lung adenocarcinomas, one of the oncogenic mutations that occurs is a fusion mutation whereby the normal ALK gene gets fused to the EML4 gene on the same chromosome. When transcription occurs, this new fusion gene creates a protein that no longer does its job. And what the protein ends up doing is actually sitting within the cell itself, not within the cell membrane. In addition to basically not acting as a bridge to proper cell signaling, controlled cell signaling anymore, one of its other kind of gain of function activities is to be constitutively activated, which is a fancy term to say that it can now send a signal downstream without the former upstream control of having a ligand to start that process. Kind of like having a light switch that's on all the time and there's no way to turn it off. Therefore, the control that formerly was held with regards to cell growth and division has now been lost. And the fused ALK EML4 protein is sending its signal through the other kinase proteins to the nucleus to grow and divide, grow and divide, grow and divide. All right, if pneumo medically means air, thorax, we know what that is. Pneumothorax must be air somewhere within the chest cavity. And that's exactly what's going on. Pneumothorax is incorrect air entry where it shouldn't be. When I inhale, the air goes into my lungs, but it doesn't get anywhere from there. The gases go into my bloodstream. The air does not. The air goes back out again. In a pneumothorax, air enters into the chest wall. And as air enters into the chest wall, it actually creates pressure, making the lung have a hard time to expand. There's two ways to get air into that space between the lung and the chest wall. It can either occur from the chest wall itself, as in a stab wound, or it can occur from the inside, say where an alveolus or multiple alveoli burst and allow air entry between the chest wall and the lung itself. Just like pulmonary emboli, pneumothoraces have a spectrum of severity. Very tiny pneumothoraces may be minimally symptomatic. However, if you go to the other end of the spectrum, a massive pneumothorax can be deadly very quickly. Matter of fact, while we're talking about the spectrum of severity, if we're on this most severe side here, the most severe pneumothoraces have a name for them. They're called tension pneumos. They basically break down this way. If you think about your garden variety pneumothorax, air can go into that chest wall space, but can also come back out again. In a tension pneumo, think of air entering into the chest wall as more of a one-way valve, where air is going in, but usually because of the structure of the injury, air can't get back out. So you have very quick lung collapse, very quick degradation of the ability to ventilate, and very quick mortality. Those of you that are going to work in ER and acute care and intensive areas will learn to identify these clinically by their sudden, severe onset, the severity of the dyspnea and the symptoms and the cyanosis, And some of the other clinical signs, such as tracheal deviation to the unaffected side, as air in the chest wall starts to push everything over to the unaffected side. I'm getting a little bit med-surg here, but I will mention very quickly that the treatment for pneumothoraces, including tension pneumothorax, is a chest tube placed between the ribs, sits up in the chest wall, and slowly draws out air. It either allows air to escape, or the chest tube is connected to a vacuum device that slowly sucks the air out and allows the lung to reinflate. I'm going to tell you right now, flail chest is not a disease, so I could have skipped it for this class. I'm just going to throw it in there because you're going to hear it. May as well be introduced now, right? Flail chest is a traumatic consequence of broken ribs that are no longer attached at multiple points. What happens is the patient breathes in, the rib cage expands, but the ribs that are no longer attached completely actually go inward in a paradoxical fashion. Flail chest has all kinds of spectrum of severity as well, but generally speaking, some type of stabilization or corrective procedure is needed to stabilize the ribs so that they can heal properly. Point for the picture, just for you ER, trauma, acute care people, now you know what flail chest is.